Good morning. So I would like to present to you my progress so far. The title of my PhD is going to be The Investigation of the Efficacy of Platelet-Rich Plasma Treatment in Chronic Dermatological Disorders. I'm Fanny Mesneric, and I'm a PhD student at the Department of Dermatology, Venerology, and Dermato-Oncology of Semmelweis University. My vision is that patients with chronic dermatological disorders could have a better quality of life, and I would like to achieve that by finding new topical therapeutic treatment modalities in the field of dermatology. Here you can see my two specific goals: investigating the therapeutic effects of platelet-rich plasma in the treatment of alopecia areata of the scalp, and also in the treatment of chronic wounds. First, about my first project. Alopecia areata is an autoimmune condition where we can see inflammation-induced, usually patchy hair loss. It can affect the scalp, the beard, or even the whole body, and it can lead to a serious deterioration in patients' quality of life. The lifetime incidence risk of alopecia areata is estimated at 2.1%. And regarding the treatment options, triamcinolone acetonide is the first line of treatment in localized alopecia areata. It is an intralesionally administered corticosteroid, so even it's a corticosteroid, we can see that there are some problems with this treatment modality. So when one of these, like adverse effects or steroid phobia, so when one of these problems occur, platelet-rich plasma can be a great alternative option in the treatment of alopecia areata. It is a relatively new treatment modality in the field of dermatology. It contains concentrated growth factors and cytokines, which can promote hair regrowth. It is already widely used in the treatment of androgenic alopecia, so our aim was to evaluate the effects of platelet-rich plasma on hair regrowth in alopecia areata. The clinical question was that does platelet-rich plasma increase hair regrowth in alopecia areata compared to triamcinolone acetonide? The population was patients diagnosed with alopecia areata of the scalp, the intervention platelet-rich plasma treatment injected to the scalp, the comparator was triamcinolone acetonide, also injected to the scalp, and the outcomes were hair regrowth, estimated with the help of the SALT score, which is Severity of Alopecia Tool score, adverse effects, and recurrence rates. And our hypothesis was that platelet-rich plasma is as good as triamcinolone acetonide in the treatment of alopecia areata. Here you can see some information about our systematic search and the study selection. I would like to highlight that based on the full text selection, we included 6 articles. From these 6 articles, we could conduct a meta-analysis on 4 articles, on the data of 4 articles, and an additional 2 articles are included in our systematic review. I'd also like to highlight that we could only conduct a meta-analysis in our primary outcome, SALT score. Secondary outcomes are also included in a systematic review part. So a bit about our primary outcome, SALT score. SALT score shows us the percentage of hair loss in the scalp. They assess it by dividing the scalp into 4 quadrants and assess the percentage of hair loss in each quadrant, and then multiply it with the percentages which you can see in the figure. And when we get the SALT score, we can classify the severity. All the studies included in our meta-analysis included patients with the S1 severity, and this is important because triamcinolone acetonide, our comparator, is the first line of treatment in this severity class. So here you can see our results for S-plot for SALT score, platelet-rich plasma compared to triamcinolone acetonide. And you can see here the decrease in SALT score both in platelet-rich plasma and in triamcinolone acetonide groups, and also the mean differences between the 2 groups. I'd like to highlight that the heterogeneity is high, and the potential reason for that is that in Kapur 2020 publication, the mean decrease in SALT score was much higher in the triamcinolone acetonide group than in the platelet-rich plasma group. If we look at the baseline characteristics in this publication of the 2 groups, we can see that the baseline SALT score in the triamcinolone acetonide group was much higher than in the platelet-rich plasma group. So if the baseline SALT score is higher, it is more likely for the decrease to be higher. So this can be a potential reason for the differences between the 2 groups and therefore for the heterogeneity. We also conducted a leave-one-out analysis, and we found that if we excluded Kapur 2020 publication, the heterogeneity decreased to 21%. The effect size is 1.84, which is not a clinically relevant difference between the 2 groups, and we can see that there's also no statistically significant difference between the 2 groups either. As I've already mentioned, we couldn't conduct a meta-analysis in our secondary outcomes, but I summarized the data which we've found in the included articles. And you can see here that the main adverse effects recorded in the platelet-rich plasma group was pain related to the administration of the treatment, and atrophy in the triamcinolone acetonide group, which is a more serious side effect. And you can also see that the recurrence rates were lower in the platelet-rich plasma group, and the number of cases with complete resolution was higher in the platelet-rich plasma group. So we can see here some further advantages of platelet-rich plasma treatment. The strength of this work are that this is the first meta-analysis in this topic to compare platelet-rich plasma treatment with triamcinolone acetonide treatment. It only included RCTs, and the clinical implication is also really important. The limitations are the heterogeneity and the small sample size. The clinical implication is that platelet-rich plasma can be a great steroid-free treatment modality in the treatment of alopecia areata. Given it's steroid-free, it can be used unlimited number of treatment sessions without the increasing risk of steroid-specific adverse effects. It can also be an optimal therapeutic choice in facially localized alopecia areata when steroid treatment can be contraindicated, and it can also be an alternative in case of steroid phobia. And the application of platelet-rich plasma with microneedling or fractional carbon dioxide laser treatment can be a promising way of administration, which is can be less painful and less invasive. And the research implication is that further high-quality RCTs are needed to better assess the efficacy and strengthen the quality of evidence, specifically with more longer follow-up periods when we can see further differences between the two groups and the possible further advantages of platelet-rich plasma treatment in regards to the recurrence rates and number of cases with complete resolution, and also the comparison of different ways of administration could be beneficial. And I've also finished the writing of the manuscript. So here you can see the article title, the manuscript title, and also our target journal. So the first target journal is JAMA Dermatology. And about my second project, investigating the therapeutic effects of platelet-rich plasma in the treatment of chronic wounds. Chronic wounds are common medical conditions and have a high impact on the aging population. The cost of wound management is estimated to account for 5.5% of all healthcare expenditure, and chronic wounds can also lead to a serious deterioration in patients' quality of life. The two most common types of chronic wounds are diabetic foot ulcers and chronic venous leg ulcers, and here you can see the incidences of these ulcer types and also the annual cost of ulcer management in Europe regarding these ulcer types. The standard treatment is smart dressing and compression, but the special bandages which are used are not the only thing which are making the ulcer management so expensive, but also the human resources, because the recovery time is really long. So if there's an additional treatment modality which can shorten this recovery time, it's not only good for the patient's quality of life, but also can be beneficial for the healthcare system. So platelet-rich plasma, if proven effective, could be this new additional treatment modality. As I've already mentioned, it contains concentrated growth factors and cytokines, which can not only promote hair regrowth, but also tissue repair and regeneration. So our aim is to evaluate the effects of platelet-rich plasma on wound healing in chronic wounds. The clinical question is that does additional therapy with platelet-rich plasma enhances wound healing in chronic wounds compared to conventional ulcer therapy alone? The population is patients diagnosed with chronic wounds. The intervention is platelet-rich plasma in addition to conventional ulcer therapy. The comparator is conventional ulcer therapy alone, and the outcomes are wound size, complete closure, pain, and recurrence rates. Our hypothesis is that additional treatment with platelet-rich plasma is superior to conventional ulcer therapy alone. The clinical and research implication is that platelet-rich plasma could be a new, safe, well-tolerable add-on treatment modality in chronic wound management. You can see here some information about our systematic search and study selection. We found 51 eligible articles based on our full-text selection, and currently we're working on the data extraction of the secondary outcomes. And here you can also see a summary of my two projects. And I would like to thank you for your attention, and if you have any questions, I'm more than happy to answer.
Thank you. It was a truly amazing presentation. My only question is that you said that platelet-rich plasma can cause pain, and I'm just asking how severe that pain is. Can it cause treatment discontinuation or decreased compliance?
Thank you for your question. No, it didn't. I mean, the cases reported didn't detail anything like that, like they had to discontinue the treatment. It was just an inconvenience, which is also important in case of chronic disease like this, when a repetitive treatment is usually needed. But it's not a threatening treatment. It just needs some more thought, like, for example, different ways of administration in the future.
Congratulations to your already submitted publication. So good luck.
Thank you.
Excuse my ignorance, but the first project, both treatments are applied topically, locally?
Locally, but it's an intralesionally administered, so it's injected to the lesion.
It's injected,
yes,
both the steroid
yes,
and the...
Yes, they can be applied topically, but I mean in a cream format or in a case of platelet-rich plasma after microneedling, but in this case it was injected.
And what is the cost difference between the steroid and the platelet-rich plasma? Have you done any analysis on that?
Thank you for your question. We couldn't conduct an analysis on that because the articles included didn't report on this data, but in general we can say that triamcinolone acetonide treatment is not an expensive treatment modality, and platelet-rich plasma treatment, you have to get the device once, and then after that you only need drawing blood from patients and use that one device. So in the long run, for a clinic, it's not an expensive treatment modality.
So you use the patient's own blood?
Yes, the patient's own blood, and platelet-rich plasma, as we can already see, can be used in different dermatological disorders, so it can be beneficial to get one device and use it in many patients.
Thanks.
Thank you.
I got a short question, excuse me. What is the time duration of the effect of platelet-rich plasma?
Thank you for your question. In our meta-analysis, we included data about the 12-week evaluation, so the 12th week after the first treatment session. But we can see in other articles which had a longer follow-up period that the more beneficial effects of platelet-rich plasma came up later as well. That's why it would be also beneficial to have longer follow-up periods, because in the 1 year follow-up time, platelet-rich plasma had better results based on several articles, but we couldn't conduct a meta-analysis on that, unfortunately.
I have a question as well, or if we could go back to your forest plots. You were saying that minus 1 point something was not, 1.8 was not clinically relevant. You're saying that. So if I'm checking the articles and I'm checking both interventions, platelet-rich plasma and triamcinolone as well, then I see, for example, in the first study, both had minus 1.3. So it means that none of the interventions was actually effective in that study. So we, of course, when we are doing randomized studies, for example, or non-randomized as well, and we are comparing two arms, we also have to see the effect of the treatment itself, not only in comparison, which change more or less.
Yes, thank you for your question. Yes, this is a good point. All the studies included individually reported a significant decrease in both groups, both triamcinolone acetonide and platelet-rich plasma groups. What you mentioned is mainly because of the low baseline SALT scores, probably, and also based on the short follow-up periods. But if we continue the treatment, we can see bigger improvements. Thank you for your question and comment.